Today, we have a special lecture. This is the Kessler lecture, sponsored by the Division of Rheumatology, which I'm going to get folks in a minute here. But Dr. Jon Giles is here with us. And so in regards to introductions, I'm going to turn it over to Dr. Beth Rubenstein, who is the current interim chair for the Division of Rheumatology, Allergy, and Immunology here at VCU and Associate Professor of Medicine. Dr. Rubenstein, I'll let you come on up.
Thank you so much. All right, it's my pleasure to welcome all of you here to not just internal medicine grand rounds, but to the 2022 Kessler Educational Scholarship Series. I don't know, it's a long name, but it says a lot. This is sponsored obviously by Rheumatology, Allergy, and Immunology Division here, and it started in 2016. We've had a lineup of really great speakers, and this is no exception here, Dr. Giles. This was started by members of the Kessler family to sort of promote education for healthcare providers for chronic disease. And so we're excited to introduce this year's speaker, Dr. Jon Giles, who joins us from Columbia University, where he's Associate Professor of Medicine. I'm assuming that's still accurate.
That is.
Okay. And he has gotten his MD from Vanderbilt. He completed his medicine residency from UC San Diego, his rheumatology fellowship at Johns Hopkins University, and now he's employed at Columbia as a clinical researcher and epidemiologist. He has investigated the relationships of immune and inflammatory biomarkers with disease activity, joint damage, body composition, cardiovascular and pulmonary disease as it applies to people with rheumatoid arthritis. And he's also focused his research on the accelerated atherosclerosis that occurs in rheumatoid arthritis, as well as myocardial dysfunction. So a lot of our cardiologists are going to be meeting with him, and they're excited to hear what he has to say as well. So today, I think the title is Screening and Management of Cardiovascular Disease in RA, and I'm going to welcome him to the stage to enlighten us for today. Thank you so much for joining us. Oh, and by the way, he is a native of Virginia, Franklin, Virginia. Franklin County, in the southwestern part of Virginia. So it's always great to have him back in the state. So thank you.
Thanks. Well, it's my pleasure to be here, and thanks for inviting me. It's nice to be back in Virginia. I was recently at the Virginia Society for Rheumatology meeting. We gave a very similar talk, and that was in Virginia Beach. I had never been to Virginia Beach before. I think I've been to Richmond maybe 4 times in my life. So it's nice to be back in Virginia. So as mentioned, we will be talking about the screening and management of atherosclerotic cardiovascular disease. Don't have enough time to talk about the myocardium today, but we'll be talking about the blood vessels. How do we advance? Click. Okay, there we go. Here are some of my disclosures. Nothing that's actually all that relevant to this talk. So I recognize that this is a general medical audience, so we'll start by reviewing the features of rheumatoid arthritis and a little bit about the immune and adaptive immune system's role in atherogenesis. And then we'll be talking about specifically RA after that. So a little bit about rheumatoid arthritis to get everybody on the same page. So rheumatoid arthritis is an autoimmune disorder. Prevalence is about 1% worldwide, so 3 to 4 million people in the United States. Just to put a number on this, that's more than the combined prevalence of multiple sclerosis and type 1 diabetes combined. So there are a lot of people with rheumatoid arthritis. The peak incidence is of the 4th to 6th decade. The female to male predominance is 3 to 1. And it has a number of features. Synovitis is the main feature that we think about with rheumatoid arthritis, and that's in the joint swelling that we see. But there are a lot of systemic features, including systemic inflammation, a number of extra-articular features, and there's an increase in morbidity and mortality with a reduction in life expectancy by anywhere between 7 to 10 years. That is luckily decreasing, and most of that is because of cardiovascular disease. So we normally think about RA as the combination in any one patient as a combination of immunopathologic features like synovitis, systemic inflammation, other types of immunoactivation, and then autoimmune features because there are autoantibodies with this disease. And this combination leads to the phenotypic features that any one particular patient will experience, including cartilage destruction and bony erosions in the joint, generalized symptoms like fatigue and constitutional symptoms. The topic of today is cardiovascular disease and specifically accelerated atherosclerosis. different types of pulmonary disease, including interstitial lung disease, which can be fatal. Others like malignancy risk, higher risks of osteoporosis. So when we think about rheumatoid arthritis, it's not just a joint disease, it's an entire body disease. And the combination of these phenotypic features leads to the deconditioning and disability and depression that patients can have. And when we try to treat this disease, we're trying to treat these features and reduce some of these adverse outcomes. A little bit about the pathobiology of rheumatoid arthritis. We won't go into detail here, but we'll be talking about the pathobiology of atherosclerosis in just a little bit. And I want to emphasize some of the similarities. So the central cell type in rheumatoid arthritis is the macrophage and synovial macrophages that produce a number of inflammatory cytokines like TNF-alpha, IL-1, IL-6, and others. But there's also important roles from T cells, B cells, and other cell types. Now, when we think about atherosclerosis, there's a lot of similarities here. We have activated monocytes in the lesional wall of the atherosclerotic plaque. They also, just like in the synovial macrophages, produce inflammatory cytokines like TNF-alpha, IL-1, IL-6 that also drive atherogenesis. There are also resolution macrophages as well that lead to tissue repair, et cetera. But when we think about the parallels between RA and atherosclerosis, we're thinking about these macrophages and the macrophage-derived cytokines. There's also a role of adaptive immunity in atherosclerosis in a very similar ways we see in rheumatoid arthritis with T effector cells of the Th1 and Th17 type, as well as improvements in inflammation via the activity of Tregs. So with that introduction, let's talk about what we know about atherosclerotic cardiovascular disease in rheumatoid arthritis. So one thing we know from epidemiologic studies is that RA is associated with a heightened risk of cardiovascular disease events, as well as cardiovascular mortality and subclinical atherosclerosis. And the numbers on this are that cardiovascular mortality is about 50% higher in people with rheumatoid arthritis compared with people who are otherwise similar who do not have rheumatoid arthritis. And that's also the same for myocardial infarction events. And also in all of the studies that have looked at the burden of atherosclerosis in people with rheumatoid arthritis, we see that the burden is higher. So a number of coronary calcium studies using cardiac CT have all shown that people with rheumatoid arthritis have more coronary calcium, which is a surrogate marker for atherosclerosis. And in one study using CT angiography, there were more calcified plaques, more mixed plaques, and more non-calcified plaques in the rheumatoid arthritis patients compared with the controls who are otherwise similar. But it's not just the burden of atherosclerosis in people with RA and the quantity of the plaques, it's the quality of the plaques that are important as well. So in an autopsy study, people with rheumatoid arthritis had coronary plaques that were had a more extensive inflammatory infiltrate, and potentially these plaques were more vulnerable to rupture. And then in studies using FDG PET CT, where you can get an idea about the inflammatory nature of the plaques, in one small study, the FDG uptake in the vascular wall was higher in RA patients, even higher than non-RA controls who had known coronary artery disease. And then in a study that we conducted that was cross-sectional using FDG PET, we found that both RA factors and non-RA factors were associated with the amount of arterial inflammation that you can see here in the wall. This is the FDG uptake in the wall. But we only could explain 15% of the variability in arterial inflammation by standard demographics, traditional cardiovascular risk factors, and even measures of RA disease activity. So there's a lot about inflammation in the arteries in RA patients that we don't understand. So what are the features of RA that could contribute to these findings? One could be that people with RA just have a higher prevalence of traditional risk factors. And that is true for some traditional risk factors. Smoking is a risk factor for RA and smoking is a risk factor for atherosclerosis. And that could be one of the explanations. People with rheumatoid arthritis tend to have a slightly higher prevalence of hypertension, but not diabetes. But even when you model these out, the higher smoking and hypertension doesn't explain all of the increased risk. Another is that traditional cardiovascular risk factors could have a greater impact in RA. And there is some suggestion that inflammatory risk factors in combination with traditional risk factors may have a synergistic effect. And then there are a number of RA specific factors, which we won't go into in detail. I just put these in the slide to emphasize that this is a complex problem with potentially a lot of contributors, like autoimmunity, in particular anti-CCP antibodies that we can have in people with RA, systemic inflammation that we'll be talking about a lot, some shared genetic risk factors, other types of inflammatory mediators other than just cytokines, like specific circulating T cells or specific circulating monocytes. We've done some work on periodontal disease and cardiovascular disease, suggesting that there may be a role for some of the pathogens in the oral microbiota. People with rheumatoid arthritis tend to be deconditioned and have a number of comorbidities. We'll be talking about a little bit about treatments and screening in just a bit. So if we try to understand what the impact of individual risk factors are, they vary, and they vary between women and men. And that was shown in this relatively large study, multinational study. Here you can see that in women, the impact of smoking and hypertension is very large, and as large as the amount of inflammation is measured by the disease activity score, which is a measure of swollen and tender joints and systemic inflammation. But you can see that some of these risk factors don't play as big a role, like diabetes, and especially not a huge role of LDL here. If we look at men, we see a very important role for smoking and hypertension, less so for RA-specific features, and an inverse role for LDL cholesterol. And why would that be? So I want to introduce cardiovascular screening in the general population first, and then we'll talk about how using the tools that we have for the general population work and don't necessarily work as well in RA. So this is the American College of Cardiology, American Heart Association algorithm. Many of you are familiar with this. This is a current standard for the US population for screening for atherosclerotic cardiovascular disease. It's intended to be appropriate for people of middle age who do not have extremes of LDL cholesterol and do not have diabetes. So how well do these risk calculators perform in the general population? So one good study for this used the multi-ethnic study of atherosclerosis. They to externally validate the performance of generally used risk factor calculators. So Framingham risk estimator, the Reynolds risk score, which incorporates CRP, and then the American Heart Association, American College of Cardiology risk score. And just as an emphasis, these are intended to estimate an individual's risk of having a cardiovascular event over the next 10 years. And when they looked to see the difference between calculated risk versus experienced risk, they found that all of these scores tended to overestimate risk by anywhere between 25% to 115%, except for maybe the Reynolds risk score in women. It seemed to line up the best with prediction. But what about in rheumatoid arthritis patients? So in RA, these standard risk stratification tools tend to underperform, not overperform. And the best estimate of this comes from this study from the Mayo Clinic. They calculated the Framingham cardiovascular risk algorithm in 525 RA patients. They had a time horizon of 10 years in these patients, and they could see what the difference was between the predicted risk and what the patients actually experienced. They predicted that there would be 47 cardiovascular events, and what they encountered was 84 cardiovascular events, so severely underperformed. The factors associated with having an event that wasn't predicted was an older patient, being seropositive for rheumatoid factor, and having persistently elevated sedimentation rate. And when they tried to see if they could fix the calculator in some way in order to have it perform more, like including CRP with doing the Reynolds risk score, that did not perform any better. Doing a 1.5 multiplier, which has been recommended for RA cardiovascular screening, did not improve. And the only thing that actually improved it was adding 10 years to the patient's age. Again, suggesting that the RA may be a disease of accelerated aging, and that people with rheumatoid arthritis have coronary arteries that are 10 years older than what their stated age is. So what's one reason that these algorithms underperform? And one reason is something called the Lipid Paradox. And this has been observed in several cohorts. And what was observed is that RA patients who have the lowest levels of total cholesterol and the lowest levels of LDL were the ones who had the highest risk of having a cardiovascular event. Now, we wouldn't normally think about this for the general population, but this is what was observed. And then the patients with the higher levels of LDL did not seem to have that much of a risk. And we asked the question within a cohort study that we put together, what is underlying this? Is there a greater burden of atherosclerosis in these patients? So this is a combination of several cohort studies of RA patients who underwent coronary calcium scoring compared with the multi-ethnic study of atherosclerosis. So these are the RA patients. This is coronary calcium score according to strata of LDL. And then here in the gray diamonds is the multi-ethnic study of atherosclerosis. So here you can see that the predicted general population relationship of LDL with coronary calcium score is the folks with the lowest LDLs had the lowest score and the folks with the highest LDLs had the highest score. In RA, as you can see, there was this U-shaped relationship that was very similar to what we saw here, where the RA patients with the lowest LDL had a greater burden of atherosclerosis compared with the controls. And as you went up, here we did see that the RA patients with higher LDLs had a coronary calcium. These analyses excluded statin users, which was an important aspect of trying to figure this out. And we observed the same pattern for total cholesterol, but not for HDL or triglycerides. And then we looked to see what was it about this low LDL group that would suggest that they would have more atherosclerosis. There wasn't. There were more smokers in this group, but they didn't have more traditional other risk factors, and they didn't have higher RA disease activity. Their SED rate, CRPs were not higher. So it really is a bit of a mystery, both why they have this very low LDL and why that LDL is associated with a higher plaque burden. One reason behind this could be that we're not just dealing with the concentration of LDL, but we're dealing with the atherogenicity of both LDL and other lipoproteins, because they do change in the context of systemic inflammation. So in the context of inflammation, you have more small LDL particles, and these small LDL particles are able to passively diffuse across the endothelium. There's oxidized LDL, which is scavenged by macrophage foam cells, and that's that oxidized LDL that initiates that cytokine and chemokine cascade in the vessel wall that leads to inflammation and vascular remodeling. And also HDL changes in the context of inflammation and becomes what has been termed pro-inflammatory HDL. You have oxidation of lipoprotein A1, which results in defective reverse cholesterol transport, which is pro-atherogenic. And there's a loss of other anti-atherogenic cargo as well. And all of these features have been shown to be present in rheumatoid arthritis. So if we accept that screening is suboptimal in our RA patients, what can we do to mitigate cardiovascular risk? So we can just treat everybody. We can say, okay, you have rheumatoid arthritis. I'm going to treat you as if you have at-risk coronary plaques. So if we do that, then what risk factors do we concentrate on? How aggressively do we treat patients? And who decides on this treatment? Is it the primary care physician? Is it the rheumatologist that's going to treat cardiovascular risk factors? And we'll talk about that in just a little bit. Another is to just maximally treat the inflammatory features, which we as rheumatologists concentrate on. We try to maximally treat every swollen joint down to being not swollen, and even potentially all elevated inflammatory markers down to normal. But the question is, does every patient need the maximum of treatment to remission? What about patients who their joints look fine, but they have some low-level persistent CRP elevation? Do we need to be more aggressive with them? And we don't know the answer to that. Another is a screen everyone approach, but as of right now, we don't have a RA-specific screening test that is both feasible and cost-effective. And then the other is an individualized approach, which we are trying to develop so that we can use the right screening and treatment for the right patients. And we'll talk about that in just a bit. There is a screening and management guideline for cardiovascular disease published by the European group called EULAR. They updated this back in 2015, 2016. They intend this for all inflammatory arthritis, not just rheumatoid arthritis. Their highest strength of recommendation is to optimize disease activity, but the rest of the recommendations are based on very, very low level evidence. They recommend screening for every 5 years. This is where the 1.5 multiplier comes from. So you take someone has a expected risk of hard outcome of 5%, then you're supposed to act on a 7.5% is what the 1.5 multiplier means. They do recommend some secondary screening with carotid ultrasound for this particular guideline, managing traditional risk factors according to local guidelines, minimizing NSAIDs and corticosteroids, which we'll talk about in a little bit, lifestyle changes, which we'll talk about in a little bit. And here, the most controversial part of these recommendations is that the rheumatologist is responsible for all cardiovascular risk management and screening, which a lot of cardiologists or a lot of rheumatologists are not willing to take up. And we'll talk about that in a bit too. There's also been efforts to derive RA-specific risk calculators by adding the RA features into traditional risk factors. And that came from this particular study from 24,000 RA patients. They were enrolled in a North America-based registry called Corona. They used a base model that included traditional risk factors, such as age, gender, diabetes, hyperlipidemia, hypertension, smoking. The AUC for this model for predicting 10-year risk was 0.726. Not bad, not terrible, but not great either. You're going to miss patients and you're going to miscategorize patients with this. If they included RA-specific features like a CDI, which is a measure of disease activity, HAC, which is a measure of disability, current prednisone use, and an RA duration of greater than 10 years, you got the AUC up to 0.76. And it did recategorize some patients. Some got recategorized down who did not end up with events, and many who got categorized up, many of which had events too. But when this expanded risk score is what it was called, was tried to be externally validated in a number of other populations, it actually didn't predict any better than the standard background risk calculators. So this is not currently a risk calculator that is being used in people with RA. So we need more work. But actually, the American College of Cardiology, American Heart Association calculator already includes rheumatoid arthritis. It's considered a risk enhancer. And we can see some of the risk enhancers that are listed here. And we have inflammatory diseases, especially rheumatoid arthritis, psoriasis, and HIV listed here as specifics. So what are you supposed to do with a risk enhancer? So a risk enhancer, depending on what your background risk is, could entail doing some additional screening or starting a statin according to these guidelines. So if someone has a 5% to a 7.5% estimated risk of having an event over the next 10 years, plus a risk enhancer, you could consider a moderate intensity statin for these patients. If they have intermediate risk, you could consider a statin as well with an LDL goal for these patients. And in addition, if they have a risk enhancer, you could consider, according to these guidelines, doing a secondary screening with imaging with a coronary calcium score. And why doing a coronary calcium score? So it's quantitative and somewhat reliable in that if someone has a coronary calcium score of 0, they have very little risk of having an event, even if they have multiple risk factors and even if they have very active RA. What about if they have a coronary calcium score that's high? And the accepted threshold is about a coronary calcium score of 100. So a coronary calcium score greater than 100 means this person has atherosclerosis, they're at higher risk, even if they have no other risk factors. And these are people appropriate to initiate statin therapy. So we wanted to ask the question, is rheumatoid arthritis actually a risk enhancer? And what would be the utility of doing secondary imaging screening with coronary calcium in people with rheumatoid arthritis? So for this, we again used the combined cohort studies. These are the investigators from those cohort studies. There was a cohort from Johns Hopkins, which I was involved with, from Pittsburgh, from Vanderbilt, and then a newer cohort from Columbia. So we had over 600 patients in this, these are all RA patients who underwent coronary calcium scanning. We excluded the people taking statins. or who had prior cardiovascular disease. So we had about 550 patients, and the controls were again from the multi-ethnic study of atherosclerosis. So when we stratified these patients according to what their ACC-AHA score would be, most of the patients had a predicted risk of less than 5%. About a quarter were 5 to 15%, and really a minority would be considered at intermediate or high risk, which is about 16%. Then we looked to see who had a coronary calcium score greater than 100. About a quarter of the patients had a coronary calcium score greater than 100. This was higher than the controls. The odds for RA was 2.5 times higher for having a coronary calcium score for the RA patients compared with the controls. So if you were just going to screen everybody, the number needed to screen, which is this and an S here, for RA would be 4. You would need to screen 4 people to find one coronary calcium score greater than 100. For the controls, it would be 8. So you could almost argue that it would be feasible to screen every RA patient. But if you divided them up into the first risk, you look at the people who are at the higher risk, they had more coronary calcium than the controls, 3.5 times higher, and you would only need to screen 2 people to find a coronary calcium score greater than 100. If they were in this intermediate risk category, they also had more coronary calcium score greater than 100 than the controls, and about a third of them had coronary calcium, and about a third of them had a coronary calcium score of 0. So this is a group that would be very appropriate to do the screening in, and you would only need to screen 3 people to find one coronary calcium score greater than 100. And you would also be able to reassure a large proportion of these people who didn't have any coronary calcium at all. And then the apparently low risk, they had more coronary calcium score greater than 100, 2.5 times the controls, and the number needed to screen here would be 12. So again, I think the concept here is that for the higher risk patients, if they're already high risk, they're likely to have an intervenable coronary calcium, and this group would be appropriate just to treat with a moderate to high intensity statin. This group would be appropriate to screen. And then what we're trying to do with this apparently low risk group is to figure out, using biomarkers and other methods, to isolate who these 9% are from these people who have lower risk. And that's an ongoing project. So how are we going to reduce cardiovascular events in RA? Well, one is, what is the evidence that the medications that we use to treat the inflammatory features of RA actually are capable of doing so? And we don't have a lot of really solid data for this. We have a lot of observational data for methotrexate and TNF inhibitors, and methotrexate use is associated with a 28% reduction in cardiovascular events across a number of cohort studies. TNF inhibitors are also associated with reduction, about 30% reduction. If we compare other biologics that are not TNF inhibitors to TNF inhibitors, abatacept had similar cardiovascular rates to etanercept. In a very large safety study, tocilizumab had similar event rates as etanercept. So if we accept that there is some risk reduction happening here, a lot of the conventional disease-modifying agents that we use and biologics seem to have about the same effect. So the effect of methotrexate on events in RA was of interest to Paul Ridker and his group. And he designed a large study called CERT to test the effect of using moderate dose methotrexate in the range of the dose that we use for people with rheumatoid arthritis to see if it was capable of secondary cardiovascular disease prevention. So this is almost 5,000 people. They had either known coronary atherosclerosis plus either diabetes or metabolic syndrome, and they were randomized to 15 to 20 milligrams of methotrexate a week or placebo and followed over a number of years. Many of you may be familiar with this trial. There was no enrollment based on CRP level. And what they found was no effect. This study was stopped early for futility. And you can see here very clearly, there's no difference in recurrent events in these patients if you took methotrexate. And they had more adverse events like non-serious infections, GI effects, mouth sores, all the things you would expect for someone taking methotrexate. What about non-methotrexate, non-biologics in cardiovascular disease in RA? So we use leflunomide and sulfasalazine quite a bit in our patients. Leflunomide, we don't have a lot of good data on. It does tend to increase systolic blood pressure a bit. Hydroxychloroquine has very favorable effects on lipids, and it can result in better glycemic control. And it was associated with lower cardiovascular disease events in a large inception cohort of RA patients, which is shown here. We do tend to use it in people who have milder disease, especially if we're using it alone. So there could be some confounding here. And what about steroids and NSAIDs? So I don't know of any study looking at corticosteroids and cardiovascular disease that does not show that they are associated with more events. They're associated with more atherosclerosis in terms of higher carotid IMT, more coronary calcium. And a number on this is the risk of cardiovascular events is 47% higher for people who take corticosteroids for all purposes, not just rheumatoid arthritis, versus not using them. But there could be some possible effects of confounding by indication because we tend to use corticosteroids more often in people with more severe disease and also who have higher levels of systemic inflammation. So there could be some of that effect. NSAIDs also have been associated, especially COX-2 inhibitors, potentially with arterial thrombosis. This may differ according to the agent. They do increase blood pressure and have other adverse cardiovascular events. But it's not really clear what the effect of NSAIDs is on actual events. So definitely corticosteroids, not a good idea. And NSAIDs we try to reduce as much as we can because they're not disease modifying in rheumatoid arthritis anyway. And since I've shown you that most of our medications are capable of having some beneficial effect on atherosclerosis, then we should be seeing a trend in declining rates among people with rheumatoid arthritis because we are very aggressive about treating our patients very early in disease. And this is called treat to target, in which the idea is that when a patient comes into your office, if they are not in low disease activity or remission, we're encouraged to change their therapy, add something else on, switch it out, because it's been shown that patients have better outcomes, and maybe even in terms of their cardiovascular disease as well. So what does the current data suggest of a more aggressive treatment in terms of events? Well, this is from a Swedish population study. A lot of RA patients are involved here, and we have a time, 4 time periods here, going all the way back to 1997, which is before TNF inhibitors were introduced, and then ending in 2014. What they found was that there is a 40% reduction in acute coronary syndromes over time in both the RA group and the control group. So events are going down in both groups, but there still remains gaps. So here you can see in the most contemporary cohort here, patients even within 1 year of their RA diagnosis, there's still a gap in events between the RA patients and the controls, and that extends into having longer RA. And this is despite the fact that the more aggressive treat to target approach was being utilized here and not so much back here. So then our next question is, if we can't risk reduce as effectively as we need to with just reducing disease activity, what about additional therapies like statins? And the question is, do statins work in RA? Because they're indicated in our guideline for people with borderline risk, intermediate risk, and high risk. So the data on statins efficacy in RA comes from a number of sources. One interesting one is a post hoc analysis of a large primary cardiovascular prevention trial. So this was high dose atorvastatin, 80 milligrams versus low dose atorvastatin. And the patients were followed for 5 years, and it turned out that there were 199 people in this trial who had rheumatoid arthritis. So they're able to look at the statin efficacy in the RA patients compared with the people who were in the non-RA patients in the trial. And they saw that the RA patients had the same cardiovascular event reduction rate that the non-RA patients had. It was about a 20% reduction in events, and they had the same lipid reduction. So statins from this post hoc analysis seem to do everything we expect them to do in people with rheumatoid arthritis. In an interesting Canadian study, patients who stopped their statins had a higher risk of MI and cardiovascular mortality. And then some evidence from a very small study that carotid plaque height got better in RA patients and other inflammatory arthritis patients who took rosuvastatin. And there was actually a very ambitious trial that was conducted in people with rheumatoid arthritis, looking at statins for primary prevention. This was called the TRACE RA trial. This is from the UK. They enrolled 3,000 RA patients to either receive atorvastatin 40 or placebo. They were followed for 2.5 years. They intended to be followed for longer, but this trial had to be concluded for futility as well. These patients were enriched for cardiovascular risk factor, and the outcome were MIs, strokes, et cetera. There was a 34% lower risk of cardiovascular events with the atorvastatin, but it was determined that they would not be able to prove, if they completed the trial, that it was statistically significant. One reason is that they had some trouble in this trial with getting the highest risk patients to be enrolled. There was very low adherence in the statin group, and there was a lot of crossover in the non-statin group. So a lot of the folks who were enrolled to take placebo actually ended up taking statins across the trial. But LDL was lower in the statin group, and there was no adverse events related to statins. And it's hard to get our patients to take a statin, especially if you have a patient who has an LDL cholesterol of 70. You say, I want you to take a cholesterol medicine. They say, Doc, why should I take a cholesterol medicine if my cholesterol isn't high? And the answer to that, I would propose for our rheumatologists in the room, is to say that we're not talking about cholesterol at this point. We're talking about plaque modification. We want to stabilize plaques, and statins do stabilize plaques. They also calcify plaques as well. So you need to expect that you'll have a higher coronary calcium score in someone who's starting or taking a statin than you would otherwise. There are dose effects between low and high intensity statins as well. And so high intensity statins do work on plaques, on atherosclerotic plaques in a better way. And the effects of statins on plaques is independent of both CRP lowering and of lipid lowering. What about lifestyle interventions? We have lifestyle intervention emphasized in the ACC-AHA guideline, in the EULAR RA guideline. Is there any evidence that lifestyle interventions work? And that was addressed in a nice little study of aerobic and resistance exercise in RA. This was a relatively small, but a randomized trial, 40 RA patients. They were randomized to either graded aerobic and resistance intervention versus advice. And this is what they did, and it's not all that intense. Aerobic exercise for 60 minutes, 2 to 3 times per week, and then some resistance exercise after. So the bottom line, their cardiorespiratory fitness improved in the RA group, and in the exercise group, and it got a little worse in the advice group. But they also improved their cardiovascular risk factors, as you would expect. Blood pressure went down, triglycerides went down, their overall predicted risk went down, BMI, but also their disease activity went down. And there weren't any changes in their medications during this period of time either. And that was not seen in the control group. So this suggests that indeed in RA patients, they can exercise and they can have improvements, at least in risk factors. But how successful can you actually make screening and prevention measures in clinical practice? And this is from Northwestern. This was a study where they were able to incorporate EMR guides and advice as to screening for hypertension, diabetes, smoking, etc. And they were able to measure and diagnose cardiovascular risk factors more effectively with these EMR guides. But they found that there was actually no change in management. So even though they were identifying more patients with hypertension, they weren't getting more antihypertensives from the rheumatologists. And the reason, when they asked the rheumatologist why this was, the rheumatologist said that they did not feel it was part of their job. And then they did a follow-up study to say, well, okay, let's bypass the rheumatologist and use non-rheumatologist providers, continue to do these risk factors and see if we can get better at treating the patient. So statin treatment improved the most. Hypertension control was getting worse, and it kind of went back to where it was. Hypertension diagnosis got a little better, and smoking cessation, it didn't change at all. So we're up against a lot of a big mountain here in terms of we can screen people, we can identify risk factors, but actually going across the finish line and actually improving those is going to be challenging. So I want to pivot for the last little bit and talk about another aspect of treating RA that has been controversial recently, and that's what IL-6 inhibitors and JAK inhibitors do to lipids and potentially to cardiovascular risk. So Totalismat was the first IL-6 inhibitor that was used in RA. In the preclinical work, it was seen that there were no changes in lipids for animals or healthy volunteers who were treated with tocilizumab. But in the clinical trials of people with rheumatoid arthritis, there were fairly predictable changes in lipids. So about anywhere between a 15 to 25% increase in total cholesterol, LDL cholesterol, triglycerides, and HDL concentrations across these trials. And it's not that every single patient goes up. Some patients don't change at all, and some patients change a lot. And so it can be a little disconcerting when you have someone who comes in who has an LDL that's 110, and you treat them with tocilizumab, and now their LDL is 180. And that is definitely something that happens, and something that was seen consistently across these trials. And it does seem that the patients who are the most inflamed and then have the most reduction in things like CRP do tend to raise these the most. So there was a trial that was run early in the development of tocilizumab to look and see about more than just the standard lipid profile, but what about other aspects of lipids, like the particle size for LDL. And we talked earlier that small LDL is more proatherogenic, and oxidized LDL. So this was a randomized trial. Patients got tocilizumab or placebo. These are RA patients. The primary outcome was the difference in the LDL particle size after 24 weeks of treatment, but they also measured other atherogenic lipoproteins and HDL cargo. The cholesterol changes were those that we would expect, but there was actually no increase in the small LDL particles or oxidized LDL, no difference at all. So even though the LDL concentration is going up, the amounts of small LDL and oxidized LDL were not going up. There were also decreases in other atherogenic lipoproteins like lipoprotein a, SPLA2, HDL-associated serum amyloid A, a big reduction, 80% reduction in the tocilizumab group. And there were actually improvements in anti-atherogenic aspects as well, 20% increase in HDL-associated peroxidase in the tocilizumab group. And this is different than other types of treatment. So one effect could be that this is just an effect from improving inflammation, or it could be an effect that's particular to tocilizumab. And that was looked at in a post hoc analysis from a trial that was head-to-head looking at tocilizumab, again, an IL-6 inhibitor, versus adalimumab TNF inhibitor. And they saw that there were higher increases in our lipid profile for the tocilizumab group compared with the adalimumab group. There was a little increase in the adalimumab group, but also similar to the trial I just showed you, there were better improvements in things like HDL-associated serum amyloid A went down a lot more in the tocilizumab group. Proatherogenic SPLA2 went down a lot more in the tocilizumab group, as well as lipoprotein A. Again, suggesting that even though the lipid panel looks sinister, underlying this is maybe changes that are more anti-atherogenic rather than pro-atherogenic. And then the FDA, when tocilizumab was approved, mandated a large phase 4 safety trial be conducted for tocilizumab versus a comparator, which was etanercept in this trial. More than 3,000 RA patients were enrolled. The treatment was not blinded, but they were followed up for 3.2 years, and almost all of the patients completed the trial for the assessment of cardiovascular endpoint, which was major adverse cardiovascular events, fatal and non-fatal MI, strokes, and sudden cardiac death. And what they found was, what we found, because I was the first author on this trial, was that the total cholesterol and the LDL went up, the predicted amounts, but the amount of major adverse cardiovascular events was very, very similar between the two groups. Now, this was a non-inferiority trial. The margin was that was pre-specified was a 1.8 non-inferiority margin, and that was well under it, because the upper bound of the 95% confidence interval for the hazard ratio, which was 1.05, was 1.43, so well below the non-inferiority margin. Now, more recently, Janus kinase inhibitors have been developed for rheumatoid arthritis, and they're being used for a lot of other things as well. And a lot of the mechanism of JAK inhibitors in rheumatoid arthritis is through inhibition of IL-6. So you may expect to see the same things that you see with IL-6 inhibitors, with JAK inhibitors, and indeed we do see elevations in technical difficulties. It's better than a big hook coming out. I guess the JAK inhibitor people. Yeah. Very strange. I tell you, Pfizer has they have a big hold on things.
They're always watching.
Yeah.
So the projector is warming back up.
Okay.
It's still showing online.
Oh, good. Okay.
This is odd. I'm so sorry.
Well, I will describe. So, so with tofacitinib, we did see the expected increases in LDL, HDL, total cholesterol, but the clinical trials didn't really show much of an increase in events, recognizing that clinical trial population is not really the general population. Usually they're healthier, they're screened out for a lot of comorbidities. That was the same for another JAK inhibitor called upadacitinib. Not much in the way of increases in major adverse cardiovascular events in the randomized controlled trials. But just like with tocilizumab, the FDA mandated that tofacitinib and Pfizer, who makes tofacitinib, they conduct a very large phase 4 non-inferiority. Oh, good, here, good. So they mandated they do a safety trial with major adverse cardiovascular events and malignancy events as co-primary outcomes. This is called the oral surveillance trial, and has been a source of a lot of controversy over the last couple of years since it came out. So these were patients who had moderate to severe RA despite being on methotrexate. They were enriched for having cardiovascular risk factors, so they had to be over 50. They had to have at least one cardiovascular risk factor, and many of them had multiple cardiovascular risk factors. Anywhere between 10 to 15% actually had known coronary disease, but they couldn't have prior malignancy. They used the same non-inferiority margin that I showed you for the on-track trial, which was 1.8. And what they found, so there were 2 doses of tofacitinib. There was a 5 milligram BID dose. This is the approved dose in the US. At 10 milligrams BID is used in Europe. 2 doses of tofacitinib versus TNF inhibitor group, which could be either adalimumab or etanercept. There's also has been concern about venous thromboembolic events with JAK inhibitors, and they did indeed find at an interim analysis about 4 years into the trial that there was a higher rate of venous thromboembolic disease in the higher tofacitinib group. So these patients were dropped down to the 5 milligram BID group, and the trial was allowed to continue, which it did complete. And what they found was that tofacitinib was not non-inferior to TNF inhibitors. So what they found was the rates of major adverse cardiovascular events were lower in the TNF inhibitor group, such that the upper bound of the 95% confidence interval for the combined doses actually went above that 1.8 non-inferiority margin, even though the actual true rate is somewhere in here, which goes all the way from being protective to above the non-inferiority margin. So in many ways, this trial doesn't tell us very much about statistically doesn't tell us very much about the comparison, but it does give us some estimates of what the rates are. So there was not much in the way of dose effect. This is wrong, actually. These are not the same. There was not much in the way of dose effect between the two doses of tofacitinib, but they were higher than the TNF inhibitor group. And it does allow us to get an estimate of the number needed to harm. So how many people do we need to treat with tofacitinib compared with a TNF inhibitor to observe one additional major adverse cardiovascular event? And that was for the 5 milligram dose, which is the one we use in the US, 567. So that's a pretty high number needed to harm. Over 5 years, it would be 113. And there were subgroups that were more at risk. So the older the patients were, the higher the baseline risk, which we'll talk about in just a bit, and smoking. And then they also saw higher risks for malignancy, in particular lung cancer in older smokers as well. So this is a subgroup analysis looking at both what the level of cardiovascular risk is in these patients. So it was pretty much equal across the groups, but there were quite a few patients who had very high risk. 11 to 12% of them had known coronary disease, and then an additional 20% were considered at high risk based on risk calculators. And what they found was that the difference between the TNF inhibitor group and the tofacitinib groups was the greatest in the patients who had a history of coronary disease. When you looked at people who did not have coronary disease, there wasn't really much of a difference between tofacitinib and the TNF inhibitor patients, suggesting that one of the screening questions that we should ask ourselves when we're going to start someone with tofacitinib is if they had coronary disease or not. And if they have, then consider treating with something else. There's also some suggestion that treating patients with statins may reduce the risk in patients on tofacitinib. This is, again, another sub-analysis. And what we were very surprised to see was that statin use was very low in this group. These are all RA patients, and it's enriched for cardiovascular risk factors, but only 23% of the entire cohort was on a statin. And even the patients who 100% should be on a statin, people who have a risk estimate greater than 20%, or people with known coronary disease, only 38% of those patients were on a statin, and only 41% were on a statin who had diabetes. So overall, the statin uptake here was low, but there was some suggestion of protection in the statin users who both had a higher ASCVD score or those who had diabetes. We're going to skip over this. Our last slide is, what do I do if I'm treating a patient with tocilizumab or tofacitinib, and they're that person that goes from an LDL of 110 to 180? Should I treat them and should I monitor them? So I was looked at in a clinical trial, relatively small clinical trial. These patients were all starting tofacitinib, and they were randomized to either co-treatment with atorvastatin, just 10 milligrams per day, not a very big dose, or placebo at the 6-week mark. And what they found was that the lipid levels went up, the expected amounts here you can see. They started tofacitinib, their LDL went up. This is the group that went on placebo, and this is the group that went on a microdose of atorvastatin, and you can see that the LDL went down, and it actually went down below the mean at the baseline as well. And that was the same for total cholesterol. HDL cholesterol went up, but did not change with the atorvastatin treatment, and triglycerides didn't seem to do anything at all. And what they found was that even though they were able to reduce total cholesterol and LDL cholesterol, the group that was on the statin actually had a better response in their joints. So their disease activity score went down and their CRP went down better with the statin than not. We still don't know medium and long-term outcomes here, but it seems like that for people who have rheumatoid arthritis and have indications for statins, and especially those for whom their lipids go up after they start tocilizumab or tofacitinib, very easy solution is to treat with a statin. So in summary, cardiovascular disease, I hope I have impressed upon you, is higher in rheumatoid arthritis. It is a major source of morbidity and mortality. It's improving over time, but has not gone away. And there are shared inflammatory mechanisms across the disease, but also disease-specific risk factors that likely play a role. Unfortunately, we do not have any evidence-based screening or management strategies that have been proven to reduce the risk of ASCVD and RA, but hopefully we will soon. We do have eminence-based guidelines that recommend a combination of screening that's appropriate for the background population, along with optimal management of both traditional cardiovascular risk factors and inflammatory risk factors. And most of that is expected to take place from the rheumatologist. And that we have novel disease-specific screening and management strategies, hopefully on the horizon, but these may involve adapting our general population screening and management strategies to the specific needs of RA patients. And with that, I'll take some questions.
Start with maybe questions in the audience. I have a couple online that I'm gonna pull up for you,
Good.
but we can start here.
Do we know as RA wanes people get older and progress through the disease, that the CV risk stays increased, or does it also seem to wane as the RA disease?
Well, I don't know if RA disease activity wanes as people get older. I mean, it's very variable. I think the one issue is that, and the one issue that makes it very difficult to assess the effect of inflammation on cardiovascular disease in RA is that today's inflammation doesn't represent their lifetime experience with inflammation. And I think we can see that in those studies where we're looking at RA patients in the very first year of RA, you still have increased risk. And part of that is that, but even before people have developed inflamed joints, they've had a period where they have elevated TNF levels, IL-6 levels, other CRP levels. So part of the acceleration of atherosclerosis probably happens even in that earliest period. And that by the time we get to treating the patients and getting their overall burden of inflammation down, you've already started those processes of atherogenesis that may continue despite that at that point. Does that answer your question?
Yeah, I think so. It sounds like it's really sort of the result of everything that's happened before when something maybe wanes.
I mean, I think that's the question is these later events we don't really know as much about. I think that's the point about the thinking about the coronary arteries as being older than the person's actual age. Oh, here are the questions.
A couple of interesting questions there. I just wanted to see if you wanted to comment
Yep.
on.
So the question, do they have elevated lipoprotein A? And that has been shown in studies of RA patients, and some of them in proportion to inflammatory markers. How do DMARDs affect? So the only DMARDs that have been associated with venous thrombotic complications have been the Janus kinase inhibitors for reasons that we don't understand. And the actual rates are not very high either. And they are likely also concentrated within subgroups of patients like older people and people who've had prior VTEs. So in general, we don't, TNF inhibitors, Totalismat, abatacept, Methotrexate is not associated with more venous thromboembolic events. So how do we separate cardiovascular atherosclerosis from hypercoagulability? So, I mean, this is an issue. We didn't talk about lupus today, but lupus also has more cardiovascular disease, and it has a greater contribution from the hypercoagulable state of lupus than RA does. What about IL-1 blockers like canakinumab and anakinra? So the CANTOS trial. So I have some slides on CANTOS, which we didn't include today. So CANTOS was very encouraging because there was about a 15% reduction in recurrent cardiovascular events in patients taking canakinumab over a period of time. We do have, in rheumatoid arthritis, one of the earliest biologics that was approved was anakinra. One of the only approvals, FDA approvals for anakinra is in RA, but we've seldom used it for RA because it just doesn't work all that well. And even though there's a ton of IL-1 as part of rheumatoid arthritis, it doesn't seem to drive the disease very much. So we hardly ever use anakinra in rheumatoid arthritis. That doesn't mean that if we did use anakinra, maybe we would see cardiovascular reduction in our patients. It's just we wouldn't get the combined effect of anakinra on IL-1 reduction and also in disease activity reduction. But I think that CANTOS, as opposed to CERT, really did prove that inflammation reduction by a specific targeting specific cytokines, could be very useful. Now, that said, canakinumab costs $300,000 a year to use it. And the risk reduction was 15%. You can get 15% risk reduction for recurrent events by losing weight and improving your diet and exercising. So, so you could, for the price of canakinumab, you could have a 24-hour in-home trainer, cook, dietitian, all those things for the price that you're paying for canakinumab. Are we seeing increased cardiovascular events with tocilizumab? So that was the point of the OnTrack trial. We did not see increased events, even though the lipid parameters changed. And that was slightly different than for tofacitinib. Oh, and then hold on, technical difficulty.
Sorry.
Good. As we have more classes of lipid lowering, right? Right, I agree. So this is now that there are different classes of lipid lowering agents, we see more uptake. So I think that right now, I think that for RA, we just need to get people on more on statins is the base. And we don't see more lipid, we don't see more statin side effects in people with rheumatoid arthritis. I think that's the biggest issue, is that a lot of RA patients will come in and say, my cousin had horrible muscle pain and I don't want to take the statin. And we can assure them, based on the data we have, is that that is not a higher risk for people with rheumatoid arthritis. Good. And then we should screen everyone with RA over 40 with a calcium score. I think that probably if you base it on just what their ACC-AHA score is and screen the intermediate people, I think that would probably get us the most bang for our buck. And coronary calcium scoring is increasingly being covered by insurance. And even if the patient has to pay out of pocket, it is not very expensive. I had a guy who went for a coronary calcium score and he paid $125. Now that's obviously out of reach for some people, but is definitely a possibility. And then someone says the canakinumab patent expires in 2024. Patents and actually what happens, mean different things. So TNF inhibitor patent expired a long time ago. We don't have biosimilars, and even the biosimilars that are available are not that much cheaper. So don't expect to be, buying retail off the shelf canakinumab anytime. But maybe, I don't know, maybe.
I think the question remains, who should be in charge? Rheumatologists or cardiologists or primary care? There's so few of us.
Yeah, I think the issue with sending an RA patient to the cardiologist is that they often don't understand the increased risk. So their risk assessment may not get the idea that, yes, your risk is 5.5 to 7.5, but it's not really 5.5 to 7.5, it's more than that. So oftentimes they just get the minimum treatment. It's not hard to prescribe a statin. Lipidologists are, it's not hard to prescribe a statin. We've prescribed Cytoxan, for God's sake. So, and high dose steroids, we have to give people, PCP prophylaxis and bone protection and all these other co-medications. You don't have to do that with a statin. Just give them a statin. It's not hard.
Who are intermediate risk, you have to kind of do more than not just.
Yep, you do.
Pick the right patient and monitor them. I think you already do a lot. Sometimes it becomes.
I know.
There's just more cardiologists.
There's just, right, that's right. We think about it like a FRAX score, for example. We do FRAX scores. That's an osteoporosis screening. It's think about it like. Good. I think that sums it up the best. Just give us that. It's not that hard. Good. But that's why I think that if we can design and validate a very effective, simple screening tool that we can use in the clinic, that's not just someone's advice, then we can get something that we can actually use effectively. Good.
think we have time for one more question here, then we'll
Sure.
wrap up.
Hi there. Plaquenil got a lot of notoriety during the pandemic, some of which was obviously negative notoriety. And in trying to encourage patients to take things, we oftentimes get a lot of resistance. And boasting about at least the modest cholesterol and glycemic benefits with Plaquenil is a good selling point. Do we have any more data to better quantify the lipid effects and the types of lipids that are affected?
Yeah, so that one study that I showed, I guess that didn't look at the lipid effects, but there are studies to look at the lipid effects. There was actually a study of hydroxychloroquine in brittle diabetics from the 80s. You know, and that's they did not have good glycemic control. They added hydroxychloroquine and they got under better control. So those data are pretty solid, I think. And then there's the QT issue, QT interval. We published a paper that showed that in RA and lupus that they didn't have a prolongation of QT interval when we used it for that indication. Great. Well, thank you all. This was wonderful.
Thank you so much.